for me a great honor to be here and amongst my Polish friends and all the famous colleagues here. Now I will tell you a little bit about things I do in my, not in my free time, my new life now. These are my conflicts of interest, and I work for several companies. So I will tell you, after more than 27 years working in the hospital, I went back to the university now, and I do research, translational research. So I help spin-offs of the university to start up a new company in orthopedics. So this is very exciting. So I will show you one example here. That's the Mobilife company, who is now working for 2.5 years. In orthopedics, we know that aging is a problem. The world becomes older and older, more older patients, and more patients should be operated on. And we all know these registers with very interesting data. I agree with the previous speaker that cementless total hip is very good, but when you see the data on the registers, they focus more on the cemented hips. But I've personally done more than 27 years all cementless total hips with very good results. I used several ones. One of them was the ABG, and there I had problems with the cup. And I know about the article of Dr. Jan Blaha, who had the courage to publish it, that the cup was not good. We know that the failure rates in total hip are for primaries around 11% and for revisions more than 25%. So there is a problem. And you know, in acetabular revision there is bone loss, and there are several classifications. One of them is the Paprosky classification. You can read it, a very good classification. Here you can see the different ways how he describes it, and this is a classification that is used especially with the idea, what are you going to do as operation, as solution for the problem. Here you see the classification with the extreme bone loss, and the worst of all is the Paprosky type 3B. This is a real problem, and we will now focus on the Paprosky 3B. Here you see another classification, the AOS, and also again the type 3 and the type 4, which is a pelvic discontinuity. In the Paprosky 3B, the pelvic discontinuity is included. But if you have a patient with a pelvic discontinuity, they have a big problem. They have constant pain, they cannot move anymore, and you have to do something for them. And what are the possibilities to do? There are possible solutions. We know standard revision cups, we know cages, standard augments, all augments that are there, and we have custom implants. We also have the bilobed cups and the oversized of the jumbos, and we know in these severe, the jumbo cup has poor results. A publication by Paprosky himself, and only 48% are stable with significant segmental deficiencies. Impaction grafting, I've used it also for some time, doesn't work. We had problems, and the survival was only 77%, and it takes a very long time to do it. I think the morselized graft or the impaction grafting in the stem is good, but at the acetabular side it's very difficult. And then we have the structural grafts. I'm not sure. Okay, the structural grafts with augments. Okay. So we have the morselized. Next one is the structural grafts, and the structural grafts have problems also. One more here at this side. Yeah. You have the publications, for instance, by Alan Gross, who said that the failure rate is 24%. This is unacceptable. structural grafts with cages, for instance, also giving big problems. This is again the article by Alan Gross. So he concluded that you should avoid this technique. Another publication, arthroplasty, also with bad results. Augments, again, standard shapes need to be combined. You have to combine things, and then you have to stack them, and then maybe they can move one to each other, and then you have problems. Is it stable, yes or no? What with pelvic discontinuity, that is the biggest challenge. You have to do something that stabilizes, you have to do something that heals, and the results are poor. With all the published reports I found, very poor and with a lot of big problems. So therefore we try to do a customized approach for these defects. And we are lucky at the University of Leuven. One of the spin-offs is Materialize, and they have a system to segment CT scans. And from there on they can construct 3D images and 3D implants, and you can do whatever. They do not only medical things, they also work for the industry and for the art and many other things. But, medical and orthopedics is a little part of their work. And together with them, we developed a possibility to make a customized implant. And now I will show you 2 case reports. One case report is a big disaster, and it was a pseudotumor after resurfacing. So I had it myself, and I did a revision. A revision failed because the bone is bad after resurfacing and pseudotumor, and the second revision failed also. So I ended up with this big gap, with this X-ray, and with a pelvic discontinuity. Okay, what did we do? Pre-op planning. So this, we take a CT scan with special software to take out all the metal problems in the radiation. Then they can reconstruct a 3D image from the CT scan. And from that image, you can reconstruct custom augments and custom plate to fix the discontinuity. In doing this, we start from the beginning with an analysis of the quality of the bone. So we know exactly where to put the fixation, where we can put screws. So the good bone is the green one. So here is not much left. And the other advantage I will show you is we have also guides, so we exactly know where to put the screws. Here you see the result of, in this case, how we will do it. And we have a booklet where we can see what step by step. So the preoperative X-ray is here. It's a big operation with a big incision. The surgical window is large. Here you see the remainings of the femoral head. We removed. Then we, in this case, I started to do with a osteotomy of the greater trochanter. It's not always necessary, but here I wanted to see everything and to be very clear what I was doing. Then we removed the component, and the cup was all out of the way. It was really difficult with the screws to get it out, but we managed to get it out. Next step is remaining screws. We knew exactly where they were, and we were able to remove all the remaining screws. Then implant. We had a model which was made before by the company in plastic, so we were able to find out exactly the method how to insert the real prosthesis and the scaffold. So first of all, we trained ourselves to introduce it, and then we implanted the real implant. And this implant is made out of titanium, and it's not simple titanium like we have it from all the other companies that is molded or so. This is made by laser sintering. So it's layer by layer by layer is built up. It's growing, and you can make whatever you want. You can make the inside of the porous coating, and the plate is in one layer, and you can make large pores or small pores or different, and you can change the structures and whatever you want. Then next interesting thing is the drill guide. Everybody knows what the companies are now doing with the total knees. Patient-specific instruments, patient-specific drill guides. These are made by Materialise for all the other companies like Stryker, Biomet, and so on. And also here we are able to use these drill guides. And the advantage is we know exactly where we are going to put our screws out of the dangerous zone, so in the safe zone, and we know exactly beforehand how long the screws will be and where we can exactly put them. So here I used some grafts, designed the implant so we had space enough to have grafts. Then we put the drill guides on, and then we drill the holes, and we use therefore the drill guides, and then put screw by screw by screw. Here again, and then after that we had to use a cup, and in this case I used a double motion, double mobility cup, and we had to cement it into this plate. So there is not yet a possibility to click in a cup in this plate because of patents. All the big 5 American companies take the patents for them, and the small companies from all over the world with the new ideas, they are not allowed to use their patented fixation devices. So we cemented a double mobility in there, then we put a new head, and we did reduction, and then closure, and so on. So this was the first case. And here you see the post-operative X-ray, and you can see we used long screws, and now I'm not afraid anymore. I'm using even long screws going all the way up inside of the ilium wing. So we have very, very good fixation. Before that, I was always afraid that the screw would end here or there, and you know, that's a more dangerous area. This is after 6 months, and this patient is now 2 years post-operative, and she's doing very well. What is interesting is also that the company is able to do a finite element analysis of the whole compound, of the metal and the bone together, and we know before the operation how strong our fixation will be. So here again, I will show you my conclusion, and the conclusion is simple. Complex defects can be treated adequately with this system. Thank you. Dr. Delport is not able to come due to personal reason, but I know him very well, and we live very close to each other by helicopter, 30 minutes, by traffic jam, more than 2 hours. So I'm pleased to, my disclosure is the same, I'm pleased to give his presentation, which we have discussed previously a few times before this meeting. It is about a new idea, which is already very old, the bi- and the three-compartmental replacements. Do they make sense? And you know all the different types that are on the market, some for a long time, some more recently. So the key points of the presentation is we should stay patient-focused for the treatment. We are looking for functional results, not X-rays. It already exists, and does it exist? This bicompartmental disease, a little bit about the designs, a little bit about disease progression, technology, and then the three-compartmental replacement. We will not waste your time. in fact, there is only one treatment for multi-compartmental arthritis, and that is total knee arthroplasty. But we know 20 years of survival rate, publications in the clinical orthopedics by Insult, 91% success, by Ranamat, 85% success. And what are we doing with the total knee? We take out the natural varus, what we know when we put is 3 degrees, and we put the tibia in a relative valgus position. At the femur side, we take out the natural valgus, we go from 9 degrees to 6 degrees, and we take the flexion out of the femur, the slope out of the tibia, even in the cruciate retaining we go to 3 degrees, and in the posterior stabilized we go to the 0 degrees. And what happens when you do that? You change the patellofemoral joint line. So by doing this we have sizing problems because we change anatomy. We are decreasing the posterior condylar offset, which is necessary. We overstuff the anterior part and we change the joint line height. And what do our patients need? They need to do something like this, kneel and other functions. So the knee function, when you need a knee function, what everybody likes to have, we can think about retention of the cruciates. What is retention of the cruciates? It maintains basic features of the normal kinematics. And this is an article by Scott Banks. Scott Banks on the left here. Daryl De Lima on the other side from San Diego, also interested. And me in the back, and we are drinking the best beer of the world in Dubai. Retention of the cruciates. We have to maintain stability, and we have to compare this with the native knee. And we have to be careful with the soft tissue envelope. So releasing Leo Whiteside, everybody knows the book of Whiteside, release, release, release. So I started to do a study on cadavers where I evaluate the role of the collateral ligaments in varus and valgus stiffness, and I use extensometers, and I measure the strain in the collateral ligaments. And then I control it with Vicon data that's for the kinematics. So this I will present next month in a forum in Leuven. So the knee function, you need to do retention of the both cruciates. When you do a total knee, you resect anterior or anterior and posterior cruciate. And why are these ligaments there? For a better rollback, for better kinematics, and proprioception. Remember, your ligaments and the envelope is there not only for mechanical reasons, but your ligaments are sensors. They are measuring what you are doing in space with your, and then they have feedback to the muscles. And this feedback goes very fast, milliseconds, and only 10 Newton is enough to have this reaction. That's not much. Now a little bit about the terminology. We have unicompartmental, that can be medial, lateral, or patellofemoral. You can have a bicompartmental, and that's a uni with a patellofemoral, a medial unipatellofemoral or a lateral unipatellofemoral. Then you have the bi-uni, that is a medial and a lateral unicompartmental and not a patellofemoral. And then the 3 compartments is the tricompartmental, of course, with 3 different implants. This has been done already a long time. Laskin had published on this in 76 already. Swanson 85, Stockley in 90. And maybe some of you remember the Canadian Cloutier from Quebec. He developed an implant, a total knee, with preserving ACL and PCL with good results, but it disappeared. Why? Polyethylene, of course. Second question, other question is, does bicompartmental disease really exist? Yes, it exists, because if you look at X-rays, if you look at patients, we see that the distribution of the osteoarthritis is most of the time medial and patellofemoral or medial patellofemoral compartment. 1/3 of the patients is like that. And you remember the Oxford publications, if you do a medial uni, and there is a little bit of a problem patellofemoral, don't bother. But be careful if there is lateral degeneration. And then there is a very nice article in the Cartilage about the patterns of wear by Bay. And the first pattern is A, small lesions. Second pattern is B, predominant medial femoral condyle and a little bit of patellofemoral. The third is C, predominant medial condyle and lateral condyle. And the fourth pattern is D, predominant patellofemoral joint and a little bit of medial. So here you can see the different patterns. The B, more medial femoral condyle, smaller patellofemoral. The D, predominant patellofemoral joint and a little bit of medial femoral condyle. And that is the theory they developed of the centroid, the moving centroids. So the center of the arthrosis starts at the medial condyle, then moves up, and then at the end goes to the lateral compartment. So bicompartmental disease exists, grade 4 bicompartmental arthritis, medial compartment arthritis with a little subluxation of the patellofemoral joint, be careful, and patellofemoral arthritis with associated medial compartment degeneration exists also after meniscectomy. Now about the designs. This design is a monolithic design, a medial condylar and a patellofemoral. It is the deuce, if you, everybody recognized it. Or you can have modular, a separate medial uni and a patellofemoral. So these are these possibilities. And the deuce bicompartmental, there are two publications about the deuce. One is by Rolston, 95 patients, very good result, but short follow-up. And the other one, also by Rolston, also with very good results. But these two publications are by the designer. There's another publication by Palumbo, recently, 2011, and 31% is not satisfied. He is not a designer. And another publication by Morrison, early function is okay, but high complication rate, also a non-designer. So two publications that this implant is not so good. Here you see the implant, and what are the problems? Why are they not so good? This is again Scott Banks from the University of Florida, who presented this in a poster in 2010, the morphology of the distal femur for bicompartmental arthroplasty. And he took 117 CT scans and found out that there is a highly variable relationship between the condyles and the trochlea, with a standard deviation of 4 millimeters. That's too much. So most of the time, this implant never fits. And that is the problem with the use. So here you see the anatomy, and the problem is always there. Bicompartmental arthroplasty, modular then, the other solution. This is a publication by Heise with only 9 patients. No revision, long follow-up, but small. Then the group of Parate. Parate is now, he worked in the Mayo Clinic, is now an associate of Jean-Noël Argenson in Marseille, and he looked at the patients by his previous boss, Dr. Aubagnac, and 155 cases bicompartmental, and very good result, except the patella was a problem. The patella was an uncemented version, and it failed. But the system itself was good. So disease progression is another thing to discuss. It progresses, okay, but different from every type. The types are different. And no disease progression was reported in the tricompartmental, three publications. Now, maybe we are interested to do this, but I don't want to do this operation because it looks too difficult. We can help ourselves with quantified MRI to find the indication. We can use navigation. We can use robotics. We can use customized implants from Conformis or from Mobilife, for instance. And we can use patient-specific instruments. Here you see the pictures, and from this the instruments are developed. And then you can do this implant, a tri-compartmental arthroplasty with the anterior cruciate and the posterior cruciate and the medial and the lateral. The whole envelope is still there for your proprioception. And the X-ray looks good, and the patient feels good also. Not good X-ray, patient bad. This time the patient feels good. And this is the X-ray of the patient after 30 years of follow-up. So in summary, don't totalize all your knees. The diagnosis must be done and treat it adequately. Use individual components and combine them. There is available technology for accuracy of implantation, and this replacement, the tri-compartmental replacement, can be a prevention of wear. Thank you for your attention, and everybody is invited to this meeting in Florence next year.
Thank you.